you can roughly tell me which chamber you see on a plain film, but just for revision's sake, on the right side of the sternum, the heart should be visible for about 1/3 of its width. The rough rules or the rule of thumbs that we use in day-to-day life are just that. They are rough. They are not absolute. So you have to interpret it with keeping in mind the quality of the film, the size of the patient, and the extent of inspiration or the angulation of the patient while that X-ray was taken. So don't focus too much on the absolutes, but just for rough rule of thumb, you should be able to see at least 1/3 of the heart on the right side of the midline. The right side of the heart is made up by the right-sided chambers, but more importantly, from cardiac point of view, you have to remember that the right-sided chambers are anterior, the left heart is posterior. So the heart isn't sitting straight inside your chest, right to left, like the body is. It's rotated on its axis. So if you were to open up somebody's chest, what would be staring you right in front would be the right ventricle. So that's the most interior part of the heart, and that's right behind this part of the sternum. So that would be the right atrium. This would be the left ventricle, left atrium, and the aortic knob. This part can be quite prominent, especially in young people, so don't worry too much about it if you do see it prominent, because if there was a vascular abnormality, it just being visible on that side would be low. So almost always it's usually a normal variant, and you can see it more prominently in young and thin patients. Something to keep in mind is the overcalling of cardiomegaly on plain film, be it the frontal or the supine or lateral even, because the fat pads can look quite confusing, and early on when you start reporting, you may call it cardiomegaly or enlarged cardiac silhouette. The statement that the cardiac silhouette is enlarged would be correct, because that is all a cardiac silhouette that you can see on plain film, but you have to be able to interpret that that part is not actually the heart. It can be straightforward in thin patients or good quality plain films when you can see right through it and you are somewhat more confident that this is fat. It gets more confusing when it's an inpatient film, when it's underpenetrated, when the patient is too big and they're not really sitting up straight. This can look quite dense, or when the hemidiaphragm is a bit raised. So quite often people call this or measure the heart from here to there and call it an enlarged cardiac silhouette. But that wouldn't be representative of cardiomegaly. On plain film, it can be more confusing. Of course, on CT or MR, you're more able to be more confident because you can see that that density is pure fat. When it's quite prominent, it's really worth excluding the fact that you're not missing a hernia. So it could be a congenital hernia that contains fat. That would be more lobulated. That would be quite prominent. But in most people, especially elderly or obese patients, the mediastinal fat can be quite pronounced and shouldn't be misinterpreted as pathology. The other thing quite often missed on plain film is pericardial calcification, because usually when we do see them incidentally, it is quite thin, it is quite curvilinear and barely appreciable. So it is usually missed. Sometimes people think, oh, it's an artifact, or it's the bed sheet or something in the skin or the garment that looks like that. Is it a big blunder for you to miss it? Realistically, not, because it would be an incidental finding. The patient would be asymptomatic. You can see it post-trauma, post-pericarditis, depending on which part of the world you're in, post-TB, post-viral infections even. So if it's thin and curvilinear, you should be able to perceive it in a good quality film. In a bad quality film, you can miss it. But in an asymptomatic patient, it doesn't really need further workup or investigation. When it's quite prominent, when it's dense and chunky, that being asymptomatic, the likelihood of that being asymptomatic is quite low. So if you do notice almost circumferential, prominent, thickened, even nodular pericardial calcification, the patient would almost always have symptoms of constrictive pericarditis or constrictive heart disease. At that point, the patient would already be under follow-up with cardiac physicians. So, but it's really much easier when the more prominent it gets, the easier it is to pick up on plain film. On cross-sectional imaging, obviously pericardial calcification is very easy to pick. In contrast enhanced scans, especially aortograms or cardiac studies, when you have dense contrast next to it, it again can be missed, especially if the myocardium is quite thin and you're not really looking for it. Moving on to cross-sectional anatomy for cardiac chambers, the first and the most important point to remember is that the cardiac axis is not the body's axis. So the long axis of the cardiac or the heart is not the long axis of the body. That is really important to remember for CT, that the images are not acquired thinking where the heart is or which way the heart is facing. CT images are just literally slices or chopping through the long axis of the human body rather than the heart. There is no way of knowing how that heart will be pointing in that body, what kind of rotation is, even if the patient has dextrocardia, unless he's had previous imaging. And even if we did know, we wouldn't be able to cater imaging any other way in terms of CT. So CT images show the cardiac chambers, but they don't show the cardiac chambers along the axis of the heart. They're showing them to you in the axis of the body. So what you think might be cardiomegaly, or a specific chamber may be enlarged on a specific slice on a CT, wouldn't really be accurate, because the measurements or the normal values we use in cardiac imaging are based on echo, and all those images are acquired along the axis of the heart and not the body. What I mean by that is that the images that we acquire on echo usually across the world form the gold standards we still follow. Even for MR, we use the normal values that were developed based on echo. These images on MR are acquired along the axis of the heart, but the CT is not. So the images you would use to accurately say this chamber is this much enlarged, you can do it on MR and not on CT, unless you then reformat those CT images along the axis of the heart. So these views that you see in cardiac MR are the views that you see in echo, and you can create those views on CT as well, but you have to create them manually. Or if you have a cardiac software, it may sometimes generate it for you, but they almost always need tweaking. So you have to be aware that it always shows you the crosshairs of the axis along the left heart. You can do it along the interventricular septum. You can do it perpendicular to the interventricular septum. So you have to create those views, and only in those views that look like this can you accurately measure the chambers of the heart. Only then can you accurately give the wall thickness. So if you then measure the LV wall here and say it's thickened, if it's not an ECG gated scan, one, you don't know if that scan is systolic or diastolic, as in that specific instant, was the myocardium contracted or not contracted. The value we use for LV wall thickness is measured in diastole. So the heart has to be the maximum filled with blood, the myocardium has to be the maximum relaxed that it can be, and then you measure the thickness of the heart. If you are an experienced cardiac radiologist, you will be able, or if you learn that technique, that you will look at the valves and try to figure out, okay, I'm going to look at the aortic valve, I'm going to look at the mitral valve. If the aortic valve is open and the mitral valve is closed, I know that the patient is right now pumping blood out of the LV, so that must be a systolic phase. So now, if it's a systolic phase and the heart is contracting, it's doing its best to be as contractile as possible. At that point, you can't measure the LV wall thickness. So that value, even if it's, for example, 9 centimeters or 7 centimeters, you can't really call it thickened. So you have to make sure when you measure chambers, you do it in these views. And you have to be sure when you measure wall thickness, and for wall thickness is usually always the LV, you do it in the short axis view. In the short axis, when you measure it, we usually go for the septum. The anteroseptal wall is the most favorite, or the most commonly reproducible value we use. In that, the question I get is, well, when you're measuring the interventricular septum, aren't you measuring the LV wall and the RV wall as well? And is that an accurate value then for LV wall? Yes, it is measuring the RV side of the septum as well, but that value is so negligible that we take all of that as a LV wall thickness. This matters when it's asymmetrically thickened. When there's asymmetrical hypertrophic cardiomyopathy, it usually favors that area. It usually favors the septum or a specific area. When it's circumferential myocardial thickness, increase, it doesn't really matter where you measure it, but you want to give the maximum value that you can find. And most commonly, it is found in that region. So that's why we measure it there. And we discount the fact that you're measuring the RV wall along with it. So you just measure it there and say that's the LV wall thickness. So that's, again, to repeat that the long axis of the heart is not the long axis of the body. You don't measure your chamber size on the CT slices. You measure it in the cardiac views that you create, unless you're using a cardiac software, which I'm guessing you're not if you're reporting on call scans. The other thing, to repeat, is that the wall thickness is measured in diastole for LV. Moving on to cardiac CT specifically, this is from this for the next 40 to 50 minutes. I'll focus on how you acquire images. I don't want this to confuse you too much, so I'll try to keep it as simple as possible. But it is a basic introduction to how images are acquired, so you can have a baseline knowledge should you be interested to pursue it further. The reasonably being able to report or scan cardiac scans after sitting through one session is low. People do fellowships, people do courses. So don't be too harsh on yourself if you feel like I haven't really understood how you acquired cardiac images. So I'll try to keep it as simple as possible, catering to a junior registrars, starting with baseline, emphasizing on baseline knowledge. So coronary CT angiogram, or CTCA, or cardiac CT, is now roughly considered a replacement for invasive diagnostic cardiac angiography. Uh, Decades ago, radiologists or interventional radiologists used to do cardiac catheter angiograms. Over time, CT has stepped in. Now, cardiologists in some places report CT cardiac angiograms. So there is an overlap on how the world has evolved over the last few decades. What is different and what is similar between the two? Invasive angiogram, the resolution is different. The spatial resolution is different between the two. The temporal is different. I won't focus too much about that, but I don't want you to weigh importance of one over the other based on the resolution, because that doesn't really make a big point in convincing you for one or the other. Contrast is usually the same or almost the same for both of them, the type of contrast we use. But for coronary angiogram, invasive coronary angiogram, you're injecting it directly into the coronaries. So you've gone up the patient's leg or the arm, gone through the ascending aorta, and injected contrast directly into the ostium of the right coronary artery or the left main coronary artery. You can then take the catheter further, but wherever you want to see something, you have to inject contrast right there. So that makes it a high risk procedure. It makes it an invasive procedure. All infection prevention and all those complication risks come into play. Cost comes into play. But what it has an edge over cardiac CT about, nothing will ever be able to take that away, and that is the ability to do therapeutic intervention right there. So if somebody is booked in for a diagnostic angiogram and you saw a significant stenosis, if you had the skill and the time and the finances and whatnot, the setup, you could literally treat it, the stenosis right there. Whereas for cardiac CT, you then have to go down that route. So that is something cardiac CT will never be able to replace, the ability to intervene right then and there that invasive angiography has. But having said that, the likelihood of diagnostic angiograms turning into therapeutic angiograms, the proportion is so low that that doesn't justify the argument anymore. A lot of times, patients, even patients with significant stenosis, don't end up being candidates for stenting, and usually they come in for a second invasive angiogram to have that intervention anyway. So and that is true for USA, that is true for England, that is true for most of the world. So cardiac CT has revolutionized how we do the diagnostic part of the coronary imaging. It will give you the detail almost as good as it, and it will give you what invasive angiogram will never give you, which is information about what that narrowing is. So on invasive angiogram, all you see is the lumen of the vessel. You can see that there is narrowing. There is no way of knowing why that narrowing is there, and you assume it's a plaque. Plaques are different in morphology, in size, in risk of rupture. And that characteristic of a plaque is only appreciable on CTCA. CTCA lets you see the wall of the coronary artery. It lets you see the fat next to that coronary artery. So there's new evidence that the inflammation of the fat around the coronary artery can give you an indication of how at risk that plaque is for rupture. We know that the different morphology of plaques make a different risk profile. So we know that there are vulnerable types of plaques. So by vulnerable plaques, I mean plaques that are more likely to rupture or break away. Usually when you have a significant stenosis, eventually you will get an MI when that significant stenosis is so significant that blood can't go through. And that when you have an MI. But with unstable plaques, what you get is that plaque, even if it's not a significant stenosis, that tiny pieces from that can break away and move this into the distal vessel. So they can give you small infarct, small episodes of angina or myocardial infarction again and again because they're vulnerable. They can break away at any time, and they can even break away without exertion. So they can give you unstable angina, and they put you at a high risk of death. All that information CTCA can give you, invasive angiogram cannot. CTCA can also tell you whether that coronary has diffuse disease. So there's so many plaques and so diffuse a disease in multiple vessels or a single vessel that the patient may not be a candidate for stenting. You can also get that information from the invasive angiogram, but the detail of morphology of the plaque you can only get from the CT. So that's one or the other. You can have pros and cons, but overall, with the new NICE guide, well, they're not so new anymore. NICE guidelines have now stated very clearly for stable chest pain, CT is now the first line investigation. Any person coming into rapid access chest pain clinic with stable angina should be getting a CTCA as a first line investigation. So that means that we would require a lot more provision of cardiac CT. That means in terms of scanners, in terms of radiographers, in terms of reporters, but that is now scientifically proven to be the right way forward. Image acquisition for cardiac CT is complex. It is very modifiable patient to patient. So there's not a strict protocol that you follow for every patient. We usually end up tailoring it for a specific patient. It is based on their heart rate or their body habitus or the indication. So image acquisition of cardiac CT can be complex, but it's really interesting, and it is a huge part of being a cardiac imager. So you have to know how to acquire the images, just as important as you should know how to interpret that image. And that is the edge a radiologist has over a cardiologist in that aspect. So needless to say, you need ECG electrodes on the patient when you do a cardiac CT. Historically, cardiac CT used to have a calcium scoring or a non-contrast scan followed by an angiogram. So what the calcium scoring CT was, it was a rough indication of the extent of disease or the extent or the severity of disease or the absence of disease. So and in some places the decision is especially for private providers or internationally, it can be driven by finances or cost as well. So calcium scoring CT, if done alone, is a cheaper investigation. There is no contrast involved, so even patients with no contrast allergy can have it, and it immediately gives you a risk score or likelihood of that patient having significant stenosis. The argument there is if you don't have any calcium on your calcium scoring CT, does that mean that you don't have coronary artery disease? And the answer is no. It means you don't have any calcified plaques, but does it mean you don't have any non-calcified plaques? So there is no way of excluding that in younger patients, patients who have early onset disease or who have familial hypercholesterolemia. They're more likely to have non-calcified plaques, giving them significant stenosis compared to older populations. So really for the early 40s to 50s is where the calcium scoring CT becomes slightly less helpful, because if they don't have calcium and you're still worried clinically that they may have significant disease, you shouldn't really stop at a calcium scoring CT. Calcium scoring CT is a plain CT chest, but it is not like any other plain CT chest. You have to cater to the exact parameters, and the reason you have to do that is only then are the numbers valid. So we use something called a Atkinson score, and it is an internationally validated score that gives you severity of disease. What used to happen previously is if you had a score of 0, so the score is something a software calculates for you. If you had a score of 0, the imager would go, that's it, you don't have disease, go home. Or if the score was more than 400, they would say, well, there's too much calcium, we can't really CT you because there will be so much blooming, so much artifact, we won't be able to see through it. So go home. No point doing it. Either way, either way, they had a cutoff for less, 0 or less than 1. Don't do the angiogram. More than 400 or 600, no point doing it. We can't interpret it. And they would do it an angiogram only for the middle set. So if you had a little bit of calcium or just under 400, 600 calcium, we think that we can have a reasonable CT image for you. Only then did they go ahead and do the angiogram. That is no longer the case. And the reason that used to be the case was only because of the machines that were available at that time. So the machines couldn't cope image quality wise to be able to see through the calcium, be able to reconstruct, have smart algorithms to reconstruct or cope with the calcium around the small caliber vessels. And the last few decades that has completely changed. The machines can definitely cope. The new guidelines, the NICE guidelines, state that there is no role for calcium scoring CT anymore. So because regardless of what calcium scoring CT says, you should be doing an angiogram. Some places have abandoned the calcium scoring CT altogether. Some places have not. Part of that decision may be based on how the contracts were set up, how the CCGs or the commissioning or the financing works. Some places it is based on how the staff has been trained. So because the calcium scoring CT is easier to do for the radiographer, let's say, he can use that CT then to plan the angiogram phase on it. So sometimes it's used as a training tool, and that's how the staff or the program has been trained. So they keep doing the calcium score. It's a lower cost and it's a relatively low dose scan anyway, so they don't mind adding that on. So you will feel or see a variation from center to center. Some places don't do calcium score and some places do. And the reason for doing that may be more complex than you may appreciate. So a calcium scoring CT has to be done at a 120 kV. Any plain CT chest done for any other reason can't really be used, and you'll feel that you'll hear that question from clinicians quite often saying, oh, the patient had a CT for bronchiectasis 2 months ago, can you use that to do a calcium score? And the answer is no. The cardiac softwares are so smart that they will be able to tell if you try to feed a CT that is not a calcium scoring CT into that calcium scoring calculating algorithm to force it to do it. Some softwares refuse or highlight the fact that it's not compatible. Some softwares will allow you to force it. It takes longer, but the point of doing that number is there is no point, because that number is invalid, because the values that we use for risk profile or the calcium score of 36 are based on an internationally validated tool that is only applicable if this calcium scoring CT was done on these specific parameters. So the parameters are collimation and rotation time and the voltage and the ECG triggering. I'll come to ECG triggering in a bit, so don't worry too much about that. They are scanned craniocaudally. Not that it matters too much. You can scan caudalocranially depending on, sometimes the children, we scan feet to head for angiograms, and the reason for that is based on the hemodynamics of a younger human or a smaller human. So that's an example of calcium scoring CT that has been fed into a software. So the image interpretation software for cardiac imaging come from two different sources. So some scanner providers have their own software. So that's, for example, GE does, and Siemens does, and Toshiba does, and some specific softwares are standalone softwares or programs. So you can buy them separately. For example, Terradicon and Circle or CVI is one of them. And the standalone softwares are very good, and based on how good they are preferred by some providers. I do feel it's based on how you were trained and what software has made you comfortable, because there isn't really much difference in terms of what software gives you and what it lacks from the other, because the competition is so much in this field. All softwares are highly competitive and they are really good, so there isn't a right pick or a wrong pick. It's based on your ease and how the contracts have been set up. So when the scan is fed into a calcium scoring CT packet of a software, sometimes it needs you to circle it depending on how you are or which version you have, if you've had a new updated version, etc. Sometimes you need to circle where you think the calcium is. Sometimes the program will automatically pick it up. It may pick it up accidentally as well. So for example, if there was a speck of pericardial calcification here, the software may get confused. Low likelihood, but it may pick that up. So you have to go through it and make sure it's picked calcium in the coronary arteries and not around it, not the mitral valve next to it, and not the pericardial calcification. Once you are happy, it will give you a breakdown of specific vessel calcification. This number doesn't matter. So the value or the weightage of calcification doesn't change based on which vessel that calcification is in, if that makes sense. The overall number matters. So the higher the number, the worse the prognosis. The logic that, if there's too much calcium, we shouldn't really be doing an angiogram, what's the point? They will most definitely have significant disease, is absolutely wrong. So if you don't remember anything out of this session, I hope you remember that there is no calcium score high enough for you to be able to confidently say, that's it, the calcium score is 1100. I know this patient has significant stenosis. You can't do that. You shouldn't do that, because there is a reasonable chance, there is a realistic chance of that patient having lots of calcium, but not having significant stenosis. So at that point, if the patient is asymptomatic and there is no significant stenosis, you shouldn't be intervening on them. So that understanding will potentially prevent a patient from going down an unnecessary intervention or unnecessary treatment. So those are risks involved in unnecessary treatment. There is historically history of unnecessary intervention in cardiology that accurate imaging can help prevent, because repeat intervention on intervention is not only financially stressful, it is high risk intervention that should be avoided unless absolutely necessary. Even when you have significant stenosis, now the drive is to figure out whether the symptoms are actually related to the significant stenosis. So I could have, for example, significant stenosis in my LAD, but I don't have any symptoms. Should you be intervening on my stenosis? And the answer is no. If I have symptoms, but I have significant stenosis in my RCA, and my symptoms are vague, they can be chest, angina related, but you do stress imaging on me, and the symptoms don't reproduce itself, and the cardiologist isn't really sure whether that coronary stenosis is responsible for my symptoms. I could have aortic valve stenosis, I could have mitral valve stenosis, that could be the cause, or I could have lung disease. If that stenosis is not the cause for the symptoms, that stenosis should be left alone or medically managed, preventive medicine. So that's really important to remember. And I do feel, especially outside Europe, it is, or outside in the eastern part of the world, it is less understood, and there is a lot of aggressive management for things that may not necessarily need intervening. So that's really worth remembering. High calcium score means higher chance of having significant stenosis. It does not mean automatically that they do have significant stenosis. So careful interpretation of the angiogram is really important. Um, there is something called FFR, or further of functional fractional reserve. I will not go into that today because I do feel that's a bit too complex, but it is a further tool that we use in cardiac CT to be able to assess if that stenosis is actually flow limiting. So you'll hear the word flow limiting stenosis a lot. So by definition, the word flow limiting is a dynamic word. So if you, on a static image, you can't really tell if the flow is being limited. So that term technically is wrong. The word we use is significant stenosis. So what that means is coronary artery stenosis is divided into minimal, mild, moderate, and severe. Minimal is less than 25% stenosis. Less than 50 is mild. More than 70 is severe. The degree of stenosis is measured on cross-sectional diameter. It is not measured by eyeballing it. It is not measured by looking at the vessel in that view. You have to look at the vessel in a cross-section, and you have to look at it in terms of diameter, not area. So that's really worth remembering. Diameter stenosis on the cross-section of the vessel is the value you use to call it mild, moderate, severe, etc. So what we call significant stenosis is actually anything over 50. So moderate and severe are all significant stenosis. Then it comes into near occlusion and occlusion. Involved in cardiac imaging much that, oh, if the LED is occluded, how is the person alive? How is their flow distal to the vessel? And that's because the collaterals have opened and the flow is coming in the vessel distally from another place, or retrograde flow. Patient preparation, quite important in cardiac CT. There is a performa they go through. There's this performa they can do at home, or they can do it in the department with help from a radiographer if they're not sure about a question. Most of these questions are not to see if they're eligible for cardiac CT or not. It is to help plan the scan. It is to help understand what their anatomy looks like. So it's important to know if they ever had a bypass. That means they have grafts. So you'll have to cover from the neck down rather than just the heart, because the grafts start from the internal memory higher up. It's worth knowing if they have metal valves, any wires, valves, stenotomies, because the metal you have to be prepared for. You can find these the stuff out once you do the calcium score as well, but it's worth having that information documented to prepare you how you want to do that image. So more metal means you have to change your factors a bit to compensate for that. Rest are more like any other CT. You have to check renal function for contrast. You have to check iodine allergy. There is almost nothing that prevents you from having a cardiac CT. The only thing medically important would be anything that would be a contraindication to beta blocker. So beta blockers are medicines we use we either use the oral one or we use the intravenous one. Oral ones take longer to act, so it would be helpful if they've been on it for a week or so. If you want to give them intravenous, you can give it on the table. It starts acting straight away. They are given to lower the heart rate and regulate the heart rate. The scanners, no matter how good, always want the heart rate to be a reasonable rate. The reasonable rate being less than 65, ideally less than 60. A regular heart rate, and beta blockers help us achieve that. Even in a normal patient, if they're stressed about the scan, you put them on the scan, the heart rate goes up, the contrast goes in, they feel the warm flush, the heart rate goes up, and they're worried about what the scan will find, the heart rate goes up. So we predict that in advance, and we give them beta blocker as and when required. So anything that would prevent you from getting beta blockers is definitely worth knowing before the scan, because that can, if you have, for example, a history of asthma, and by asthma I don't mean like mild asthma. If you have severe asthma that you have been admitted to the hospital for in the past, for example, those are the questions. Those are the kind of questions you ask to find out how bad their asthma is. If they're on treatment, if they're on steroid inhalers, If they have asthma and you give them beta blocker, you can induce a bronchospasm. So generally, anybody with significant asthma, we don't give beta blockers to. And the faster and the newer scanners can cope up to a certain degree of heart rate. Of course, if the heart rate is more than 120 and is irregular, then the likelihood of getting a good scan would be quite low. So then it may be worth sending the patient back, asking the cardiologist if they want to do an invasive angiogram or they want to reconsider, um, the request. On the day of the scanning, we ask the patient not consume any caffeine. So we bring them in the morning. We tell them, after last night, don't have any caffeine. And that means no chocolate either, no chocolate, no Cokes, no Diet Cokes, no coffee, tea, etc. And the reason for that is the heart rate. The symptomatic system, it becomes excitable, and they can, if they are on caffeine, it can raise their baseline heart rate, and it can make them less responsive to beta blockers as well. If you give them oral beta blockers, we make them sit outside and we give them a couple of tablets. You can give 50 or even 100 milligrams. If you give them IV, then if you give them oral and you make them sit outside for 2 hours, you have to think, is there space for them to sit and wait? And if this is this a safe environment for to be in? If the referral is from a cardiology clinic, they may have already put them on the beta blocker. For example, at our trust, when the rapid access chest pain clinic refers the patient, and the nurses, they already prescribe the patient beta blockers to be on for a couple of weeks before the scan, because they know the waiting time, they know when approximately the appointment will be. They'll say, okay, from this date on, take the medicine. It's quite safe medicine, beta blockers. It can make you feel tired. So if you give them IV beta blockers and you're the one giving it to the patient, you have to tell them that, you may feel a bit tired, you can feel a bit dizzy if you give them a big dose, but it's nothing to worry about. It's a safe medicine and goes out of your system quite quickly. And if the patient shows up from another avenue or they still haven't responded well, you give them IV beta blockers on the table. We don't give beta blockers like we do in medicine because you're not treating anything. So we give a stat dose. You don't have to go slow. You just whack it in. We can start with 5, 10, 20. Every center has a limit up to which they will go. We try to stay below 40. Below 40, I don't like going unless I have a cardiologist next to me to handle it. If the logic of that being, if the heart rate hasn't responded by 10 to 20 milligrams, the likelihood of it responding by 40 milligrams is quite low. If it's slowly dropping but not quite dropping to the level you want it to go to, then you keep giving it. If it hasn't responded at all by 20, you should stop. If it's slowly responding, might go up to 40. The transplanted hearts have a very bizarre response. They don't really respond well to beta blockers because you've taken away the nerve supply of the heart, and the new heart isn't really connected the same way. But we do give them. They're also more tolerant to beta blockers. Most of them are on quite a bit of medication anyway. So only the transplanted hearts don't respond that well to beta blockers. Otherwise, almost everyone does. The selection of the scan protocol will then decide on the heart rate. Like I've told you, every scanner wants or asks for a low heart rate, so less than 65 is preferable. And just as important as the rate is also the rhythm. So why do we want a stable heart rate? The scanner, most of the scanners cover the heart in multiple slices. Unless you have a detector wide enough to cover the heart in one rotation, you will need the gantry revolving around it. So every time the gantry has come back up and tries to radiate the heart or get an image, it would assume that the heart is where it was the last time it did it. If it isn't able to understand that. It will just stitch the images together. For example, here in this image, if the heart rate was different every time we took an image, the image would look something like that. If the heart rate was the same every time the gantry moved down, because you're doing step and shoot rather than a helical, every time you do it, if the heart rate is about the same, you get a smooth image with no real stitch visible. How the scanner scans is it looks at the ECG, and that's why we have the pads, the ECG monitoring on. Is it goes by the R wave of the ECG. It it will watch the ECG. It will figure out where the R wave is, and depending on the rate, it will assume. For example, if the rate is, I'm making the numbers up, and they won't match up, so don't hold me to that. For example, if the heart rate is 60, it thinks, okay, the heart rate is 60, the next R wave will come in 300 milliseconds. So, and the scanner wants to scan, or does scan, every other heartbeat. It doesn't scan, it's not that fast, it scans every other heartbeat. So it will think that, okay, the heart rate is 60 right now, the next R wave will come in 300 milliseconds, the R wave after that will come in 300 milliseconds. So I will blast again in 600 milliseconds, and I will blast again in 1200 milliseconds, and that's how it will go. If by the time that the scanner revolution has come back, my heart rate has changed to 80 because I'm so nervous, or the contrast has gone in and I feel all warm and it's worrying me, the scanner won't be able to tell. It will scan. It will still give the, it will acquire an image at the 600 and the 1200 mark, but the ECG would have changed. It will no longer be an R wave, or that point, or where it was going to scan. So if the first image was about that diastolic phase, by the time it scans again, it would now be a systolic phase. But the scanner won't know that. It will assume that it's the same heart rate and will try to stitch the images together. Scanners are smart. They look at the ECG afterwards. They try to get rid of the ECG or the images that are not suitable, or the images that were required when the ECG was abnormal or not compatible with what it thought it was going to be. Because every image is not acquired by just one rotation, it's acquired by multiple rotation, multiple slices contribute to every slice, if that makes sense. So the other thing you can do is the radiographers can manually edit the ECG. For example, if this is how the images are required, and this is the irregular heart rate, and I think, well, I wanted to go diastolic. This image isn't really diastolic. It looks like systolic. So I will delete that block. I will then go for that. Something like that. That makes sense. So you can manually edit the ECG, or the scanners are smart enough to recommend that as well. But it can only do so much. If it's ruined all the slices, all the images you have, you can't really do much about it. What you then are left with is post-processing, and post-processing in cardiac imaging is extremely sophisticated. The scanners and the softwares are really good in trying to find you the best possible phase, the best possible millisecond, the best possible image, and stitch them together to make a packet for you. Some of that is manual, so that's where your radiographer comes in. Some centers are in-person supervised, so the radiologist does that as well. Certainly, as a trainee in cardiac imaging, you should be doing that, so you know how to fix a scan. No matter how senior you get, if you get stuck, you should be able to fix the scan or the image yourself, or be able to tell what is wrong with the scan. But post-processing also can only do so much. If the heart rate is extremely unstable, extremely irregular, and the scan is completely non-diagnostic, you have to then repeat the scan. I can't tell you that's a very frequent occurrence. In most centers, the repetition of a scan due to image quality is extremely rare. I think we've scanned, maybe Reese had to rescan one in the last 8 months or so. So that's how infrequent that is. ECG gating is what it's called. So we call cardiac imaging, any scan can be a cardiac scan. What is different about a cardiac scan is the fact that it's ECG gated. The X-rays are given based on where the patient's heart is in terms of the ECG. So what it uses is the RR interval. It can pick the RR interval and then calculates everything from that number. So this is what I meant by the scanner trying to figure it out. So if this RR interval didn't match with this one, it thinks that this is not a good heartbeat, it's an ectopic, I'm not going to use that. So it can automatically edit that out, or you can edit it out. This one, it thinks, yeah, I like that one because it's consistent with the first one, I'm going to use, or semi-consistent with the first one, I'm going to use that. So that's what ECG gating means. It means your image acquisition in sync with the heart cycle is what ECG gating means in CT and in MR. So you can be more, the reason for doing that is you want to acquire images in a certain phase, whether that's systolic, mid-systolic, end systolic, diastolic. The coronary arteries are maximally dilated in diastole, so they will be engorged with blood because they're filled in because it's a passive filling. They're not, blood is not pumped into the coronary arteries of the aorta like the rest of the aorta arteries in the body. So these arteries are different from the rest of the body. They are filled in diastole. So when the aorta is pumping out, it doesn't pump blood out into the coronaries. When it goes into diastole, that's where the coronary arteries fill up. That's why we want to acquire those images in diastolic phase. So the other thing we give a patient just before image acquisition is GTN. And this is something patients with angina have. It's a vasodilator. It's an immediate vasodilator. So patients get a GTN spray or a tablet under their tongue just before they're about to start the scan, because they're extreme, it's a rapid action drug and it can also cause reflux tachycardia. So we give them GTN just before the image acquisition. And the reason we do that is to have instant vasodilation. So you want every vessel to be as dilated as it can be, because these are very small caliber vessels. They're really hard to see. So that, the most we can achieve in terms of a good caliber, the better it is for interpretation. GTN, like I said, we give it just before we're about to take the patient into the scanner because it starts acting straight away. A spray is a bit messy because you don't really know how much you've sprayed in, how much you've sprayed across the face. A tablet is more accurate in terms of the dose it's delivering, but the tablet takes a while to dissolve because they may have put it in their mouth and you've taken them in, done the image, bring them out, and they'll say, okay, can you have this tablet back? Because then they were, they had a dry mouth or they didn't know that they were allowed to let it swallow. So that's the pros and cons of the two ways to give GTN. So we give GTN to dilate the vessels so we can see them more clearly. And the only vessels it will act on is for cardiac imaging is the coronaries. It won't really help with the aorta anyway, but that's a large caliber vessel, so we don't need it more dilated. So it doesn't really matter. Scanners have evolved rapidly over the last few decades. What you need to do cardiac imaging, the minimum requirement is a 64 slice CT. And I do feel almost all scanners are now at least 64 slice. The higher the spec of the scanner, better the cardiac imaging, because better the speed, better the resolution, etc. If the older generation scanners, people did attempt cardiac imaging on it. The images weren't as clear, they were grainy, and more importantly, they were really slow to acquire. The reason that is the more time you take to acquire images through a heart, the more time the contrast needs to be flowing in. But you can't really compromise on the rate because you need a certain amount of pacification. So it took more contrast, longer time, more radiation, and still a suboptimal image on the older scanners. So this is just a rough comparison of a 16 slice and a 64 slice, which is still the lowest power scanner that is acceptable for cardiac CT is a 64 slice. So you can quite clearly see the difference between the two. The newer generation scanners, you can have, any provider, any company, any vendor can give you a very high spec scanner these days. So there isn't a best scanner or the right scanner. Cardiac imaging is led just as much by the radiographer or the image acquirer as it is the CT. So you can give a flashing new scanner to people who are not trained properly to cope with different heart rates and rhythms, and you won't really get a good image. So they go hand in hand. So there's two different models of newer scanners, or the best new scanners. One is having a bigger detector width. So that's when you have a detector so wide. For example, if I'm lying on a CT scanner table and the detector is 16 centimeters wide, my heart is not longer than 16 centimeter, or maybe, so of the important bit where the coronaries are. So you can literally just take one snapshot across that detector and you would cover the whole heart. It may be different for big people, as in exceptionally tall people, but an average heart you would be able to image in 1 or 2 rotations of the gantry. So that's the benefit of having a wide detector. Even 16 centimeters you can get these days. The wider detector, less the time you need. And if you were to take, this is called single heartbeat imaging. If you were to acquire a whole cardiac CT with one heart rate, it would not matter what heart rate was, would it? Because you then don't need to have it reproducible between different heartbeats. That would mean almost, or it would mean zero movement artifact. The the patient is not only having it's not just the heart beating as well. The patient is breathing as well. So there are multiple ways artifact comes in. So just before the contrast goes in, the patient can have a sudden change in breathing, or they can move. So the artifact comes just not just from the heartbeat, it comes from the breathing as well. And breathing can ruin any scan, even if you have a 16 centimeter detector. If the patient is moving or breathing, the scan isn't good. The other scan, the way you can do a scan is you can have a higher pitch. So these are dual source scanners. And with the wide detector, it's more GE or Toshiba. With the higher pitch, if you remember from your physics, the pitch is just how tightly the ribbon is tied around, or how much overlap there is in terms of information between different slices. So uh, two different ways, just as good. The results, the higher pitch, the dual source scanners show an exceptional quality. There is very little movement. You can see through metal much more clearly because of how good the post processing is for those images. The something called multi-sector scanning. I don't want to dwell on this too much, but because I do think I may confuse you but a little bit. But it's worth remembering that we don't, just for speed's sake in cardiac imaging, we don't use we use something called multi-sector scanning. So we can use different parts of an image rotation, the gantry rotation, to create an image, but don't worry too much about it for today's session. In terms of post-processing or during image acquisition, something really advanced that has now come up in the last 3 years is something called smart arrhythmia management. This is a vendor-specific term by GE, but there are different models across. What it means is the scanner is smart. What it means is the scanner is reading the ECG while the scan is happening, which is not something that used to happen before. What used to happen before is it would acquire the images, like the below image, it would then reject it later on, but it would have radiated the patient here. What smart arrhythmia management means is the scanner is now so smart that it is reading the image, the ECG, while the scan is happening. So if it had calculated, okay, for example, this is what I've measured that the RR interval is this much. This means, sorry, I'm going to acquire the image at this many milliseconds. It then waits, but when it's turn to acquire the image, it realizes, oh no, the ECG has changed. It's no longer the right point to acquire an image, and it will stop. It won't radiate the patient. So that is really smart in the sense that it won't give unnecessary radiation. It will wait for the next heartbeat. So that's the smart arrhythmia manager. It manages itself while the scan is happening. It will wait for the next heartbeat and then scan. The downside of that is it can only do it once. So it will wait once, but the next heartbeat it will scan regardless of what it is. So there is some protection there, but no, it hasn't resolved the issue altogether. It is time for a break, but I'll just quickly go through the image acquisition and try to finish it, and then take questions when you guys come back. Detector width I've already covered. The wider the detector, less times the gantry needs to go around it. The less time we need the heart rate to be regular-ish, so the better the scan. And over time, we started from a 4 millimeter, now 16, and now it's it's now 16 centimeter detectors. The softwares give you, I think, let me go. Okay, so the softwares give you a volume rendered image of the heart once the scan is finished. What that means is it will give you a 3D reconstruction. It can look like that, or it can look like the whole heart. It is just a visual guide. It is not a diagnostic image. So this is just to tell you how and what the best guide it is for, in my opinion. It is a guide for image quality. If you do see a really nice volume rendered image, you know it's a good quality scan. If you rate or see it all choppy and blurry on this, you know it's going to be a hard scan. I'll have to reconstruct again and again. But what the image we use is the MPR in the longitudinal way, and what that shows is an MPR through a normal left ascending sorry, left anterior descending artery. And what you will do is you will be able to appreciate images there, but that's a single snapshot. That image is rotatable, so you will have to swing through that vessel to see if there's any plaque hiding elsewhere. You cannot quantify the degree of stenosis based on what that image looks like. You have to take the cursor. You can barely see the yellow one. You can carry it up and down. You carry the cursor down, and on the side you will get a cross section or a circular view through that vessel. So, for example, if there is a plaque here, I'll show you on a later slice. You can bring it down, and on the circle you will be able to see how much the degree of stenosis is. And on the cross sectional image next to it is when what you will use to quantify the degree of stenosis. Images can be acquired ECG gated in two ways. You can acquire them prospectively, or you can acquire them retrospectively. It was more important. It is less important now with better scanners, but prospective, the average scanner could only cope up to a certain heart rate, or only cope with a certain degree of heartbeat irregularity. If it was nice and regular, the heart rate was acceptable, less than 65, less than even 70, let's say, it can do a prospectively triggering. What it will do is the scanner will wait and scan every second heartbeat, like we talked about. This is called prospective scanner. The scanner is waiting for the heartbeat, scanning, waiting for the second heartbeat, after that scanning. It is not doing, and because it's prospective, because it knows what it's scanning. What retrospective means is it's just scanning throughout the whole heart cycle. In prospective, there is no radiation given here. The radiation is only given in the yellow bits. That yellow bit can be a single line. It can be a single snapshot. Those are extremely low dose images, but those are risky images as well, because you don't have any cushion. This way, you can cover for about 50 to 100 milliseconds even, and you will have a lot of different phases to look through. You can have 200 milliseconds, for example, 300 milliseconds, 320 milliseconds, if you have something called padding. But there is no radiation here. So that's a lower dose scan. If the heart rate was so high, for example, more than 75, we know the scanner won't be able to cope. It's not that quick that it will be able to do that for a faster heart rate beyond a certain number. What we then do is we ask it to scan retrospectively. What that means is it will be scanning during the whole heart cycle. It doesn't know what phase it is. Once it's done scanning, we then reconstruct the images later on. What that inevitably means is you have a lot more slices to go through. You have a lot more cushion in terms of a lot more availability, because the image quality is likely to be lower, so you need more help. But what that means also is that the dose is quite different. It is considerably higher than prospective. So just to give you an idea, it can go up to 10 to 12 millisieverts, whereas this you can finish in 1 to 2. The other thing worth remembering, this is not just cardiac terminology, is blooming artifact. Blooming artifact can happen any metallic or calcified structure. It can happen in any body part. Why it is so important in cardiac imaging is because the vessel caliber is so small that any little blooming, for example here the blooming is because of a metal artifact, that's a stent. If the image quality isn't good enough, you can't really tell where the stent finishes, because some of that is blooming and some of that is the actual metal. So it becomes really hard to figure out the degree of stenosis or the patency of the stent, even if there is so much blooming. So blooming is a real issue in cardiac imaging. The better scanners, and the higher resolution, if the factors are right, the KV is enough to penetrate through the metal, the MAs are enough to contribute enough photons to the image, and obviously the post-processing techniques. But blooming artifacts is a significant issue in cardiac imaging because of the calcium and the metal both being, the main issue for image interpretation. Um, Before I go to image anatomy, I will take a break. And then you come back, we'll move on to anatomy. I think it's 7 o'clock. So let's take a 5 minute break, or and when I come back, I'll take your questions before I start. You will see either reformat 3D of the heart, or you will see this image. This is just a guide for you to be able to know. What it will do is when you're watching the vessel or analyzing a vessel, this is a fail safe on one side. It will tell you that which, it will highlight or put a line through which vessel you're looking at, because it, believe it or not, in speed or being a bit careless, you can sometimes lose sight of, I forgot which vessel I was in or looking at. So this is just a guide on the side, making sure you know you're in the left heart or the right coronary. This is not a diagnostic image. It can be very blurry if the scan isn't a good quality. That shouldn't scare you from the scan, because the actual scan being reasonable or diagnostic quality is still pretty high. This is just a rough um, guide, basically. This is the image when we click on a, for example, if this was in front of you and you brought the cursor there and you clicked on a certain vessel, this is what it would give you. What you would do there is, you would, depending on the software you're using, you swing it around to see how it looks in different planes. What you will then do is you will take the cursor up and down wherever you think you see a plaque. So this is a non-calcified plaque. This is a part calcified, part non-calcified plaque. You will bring the cursor to that level, and then you will look at the cross section next to it. You will see that it looks like about 50% stenosis there, but you don't call the degree of stenosis here. You have to call it on the diameter on the cross sectional view of that coronary artery. The other indication, quite common indication, is to check stent patency post intervention. The reason I put it here next to image acquisition is to be mindful that you really do need to know the patient has a stent before you do the scan, because you do need higher KVs. You need to compensate for that high, that dense metal around the vessel. You can't, if the patient happen to be big or small, the likelihood of you needing to increase that KV even further because they have a stent is pretty high. So you really do need to make sure your referrers putting the request is clear what the patient has had done. If they've had a stent, you need to change the KV. We usually take it to 120, or you can change the MA, or both. If they've had a bypass, you have to open up the window, start from the neck, change the scan acquisition based on the scanner you have. If you have a very good fast scanner, you can even do a prospective cabbage or graft protocol. Patients usually may have both. They may have a stent and a cabbage, or they can have had a cabbage and the graft may have a stent in it. So sometimes, years after you've had a bypass, the stent can get in stent thrombosis, and those are treatable by stenting those grafts. So you can have both within each other or next to each other. So you really need that information before you acquire an image. The better the quality, the more easy it is to interpret the degree or the patency of the stent. If there is a lot of blooming, you can't reasonably say whether that graft or the stent is patent. The newer scanners can cope with that pretty well. They can take a lot of the blur away as well by their post-processing techniques. While we're talking about cardiac CT, I would like to talk about why we don't do it how we think we should do it, whether that's something for you to think about. We've talked about what the indications for cardiac CT, what the most common indication is, but given that it's probably the most common cause of death as well, we do need to think why we don't do more of cardiac CT. Is cardiac CT just for coronary artery disease? And obviously, I hope all of you know that it's not. You can get coronary artery disease can be atherosclerotic disease. It can be iatrogenic disease. It can be post intervention. Patient can have spontaneous dissections. Young patients with connective tissue diseases can have spontaneous coronary artery dissection. Coronary artery angiogram or invasive angiogram can't give you that answer. It's not safe to. Sometimes cardiologists can accidentally dissect a coronary artery, and then cardiac CT is helped to confirm and see how bad it is. That's just for coronary arteries. That doesn't even begin to talk about the congenital abnormalities, the abnormalities of course and origin, pre-transplant, post-transplant. Um, in terms of heart, previously cardiac CT used to be a tool that could be employed for function. That if you were to look at function, systolic function or perfusion, it needed a retrospective scan, so that's a higher dose scan. With time, the realization that such a high dose imaging modality to get information that you can get reasonably well with the echo as well made us move away from that. But now there is again a drive to get perfusion CTs and more complex functional imaging from cardiac CT, but that is because of the better machines and it's not a higher dose scan. When so it's not just for coronary artery disease. When is it justified as an emergency scan? So a patient presenting with acute chest pain into an ED shouldn't be having a cardiac CT scan. That used to be the stance for decades. With time, that stance will change. The discussions are already happening. There are pros and cons. There are people who agree with it, people who don't agree with it. But the realization that more and more EDs across the world have access to CT and how it's a safe cross-sectional imaging technique that can give you a reasonable information, why shouldn't it be used for acute chest pain? So there are both sides to the story. For now, if you are in the ED and somebody says that, oh, I think my patient has an MI, they have significant or occluded LAD, can I get a cardiac CT? And the answer should be no, because if the patient has presented in the acute window, they are treatable. So anybody who is symptomatic acutely now, that could do with therapeutic intervention, should go straight to the cath lab. There is acute cath lab provision more than there is acute CT provision anyway. It is a better stocked specialty as well, cardiology. The door to needle time or door to catheter time for cardiac angiographies is a very competitive field. So there is access to out of hours cardiac invasive angiograms, therapeutic, across the world and across the country as well. So that is the way to go. If somebody is in an emergency room and may have had an MI, they should be going to go to the cath lab. CT has no role in that. The only time CT would have a role in that situation is when they went to the cath lab. A young registrar put a wire into the LAD and they thought they dissected it. The wire went too deep into the wall of the LAD and it dissected the wall, or they think it was a dissection to begin with because they saw that the lumen was tracking into the wall and there was no other site of disease. So when they clinically think that they may have dissected or the patient presented with a spontaneous coronary artery dissection, then cardiac CT is reasonable. If they think that the patient had, they know the patient had a cabbage 10 years ago, so this is a patient with, they don't have native coronaries, the intervention slightly becomes different there. They then have a more of a cautious approach. Then they want to know, especially if it's not from that center or they don't have notes, so the patient is unconscious and unable to provide a history. They don't know what grafts they have. They don't know what anatomy is. Then they want a cardiac CT to look at what grafts he has and if those grafts are patent and what the situation looks like. Is it worth intervening? Should we put him on medical management, best supportive care, that sort of situation. So that scenario is also acceptable. The other very common scenario now is patients presenting with acute heart failure that have aortic disease. So there is a drive to doing urgent TAVI procedures, urgent aortic valve interventions. So those patients need a pre-procedure CT. That is technically a cardiac CT because it is done as a cardiac CT, and the reporters are the same, the radiographers are the same. So that's also emergency justification. So what is the limitation to performing these scans? If you look at that map, which is now I think 3 to 4 years at least old, it shows you the number of accreditors across the United Kingdom. So you can see most of the country is red. You have 0 to 4 cardiac CT practitioners per million of the population. That is a huge problem. So that shows you what a shortage occupation cardiac radiologist or imager is. there is there is a change in the recent RCR curriculum. There is more of a drive to have every radiology registrar, or there is a clear drive on it to have every radiology and cardiology. Incidentally, the cardiology curriculum has also changed. By the time they finish training, they should be competent in basic cardiac imaging. What that will mean is, even if you're not a cardiac reporter or cardiothoracic specialty radiologist, but you happen to work at a DGH and you finish training here, you should be able to have a basic interpretational skills for cardiac CT, especially for life-threatening problems. Every cardiac abnormality is technically life-threatening. The interesting thing about cardiac imaging is that you don't have a lot of differential. There are only a few diseases that can, happen to a heart or a coronary artery. What is important, extremely important compared to other modalities or pathologies, is the degree of disease being assessed accurately is extremely important. And the consequences of missing significant disease are also dire. So it's not like you can miss a significant stenosis and nobody will find out, because the patient will come back. They will come back with an MI, and you will realize that you missed a significant stenosis in retrospect. So it's not like a discrepancy in cardiac imaging can just disappear. So that's one limitation, the number of reporters. Is the second limitation scanner spec? I would say no, because most of the scanners in the UK are 64 slice and above. It may or it is true in the rest of the world, especially the less developed part of the world. It's not that, every scanner isn't that good quality, or you don't have ready access to CT modalities in other countries. Radiographer expertise, certainly as important or even more important than a radiologist, because for a radiologist you can send the images to a teleradiology firm or a remote radiologist to get reported. The radiographer has no replacement. So radiographer expertise are very important. They are rare. They're also short staffed. There is a lot of drive nationally to increase their numbers. It is a very highly stressful profession. They do a lot. They do on calls, they do trauma, they do different sorts of scan. So different centers, some centers have a dedicated set that only those radiographers will do cardiac imaging. Very few centers have almost all radiographers trained up in cardiac CT, and we are one of them. So radiographer expertise, yes, definitely. So it comes down to the person scanning and the person reporting. Scanner spec is not a huge issue in the UK. So the question then comes: is the answer no? You can't have a scan in emergency based on availability, or is it based on medicine? Is one argument that you will hear frequently in these national conferences. Coming on to on-call reporting, this will focus on quite a few abnormalities or pathologies that you will be able to pick or should be able to pick. These pathologies with faster scanners don't even need a cardiac scan. These are cardiac or cardiovascular pathologies. You can pick them on a cardiac scan, but you can also pick them for any routine scan, even non-contrast as well for some of them. So, but what happens with cardiac pathology is people who don't report cardiac imaging, this kind of in the back of their head, the middle of the chest is a black hole, and they don't even look there. And this is true especially for older generation of radiologists, because they think this is not something you look at. Cardiologists look at it in an invasive way. I'm not going to look at that. With acute reporting also, registrars, junior doctors, when they scroll through a scan, looking at a heart is not one of the first things that comes to their mind. That is really something that needs to change, especially when you're reporting in extremely sick patients, because if you miss an acute cardiovascular abnormality, it is almost always life-threatening. It is almost always an acutely unwell patient, but there will be a patient with one of these abnormalities that will not be presenting with classic symptoms, because in real life the exam or the MCQ scenario doesn't happen. The patient doesn't present with sharp radiating pain to the back with the aortic dissection. The patient may come with vomiting, or the patient may come with I can't stop coughing or something like that. So, and you also depend on the history providers, so you can't really trust the history, as I'm sure most of you reporting on call scans know. So this is just a list of pathologies. I'll go through some of them that you should be able to recognize on your on-call reporting. One of the most common asks you get or you may get on your on-call is a cardiologist asking for a scan to see if there is pacemaker perforation. So when a cardiologist has perforated the heart with a pacemaker, they know. If it happens acutely, they know because they know, their own limitations. They know the patient. The patient is in front of them. So it can happen in an acute setting symptomatically, but it can also present in a delayed manner that can be days later. So patients are usually sent home the same day or the next after pacemaker insertion. The patient can come back in a few days, 3-4 days, saying I have this dull pain and I don't really feel well. So the thing to remember with pacemaker is that the extreme tip of the lead is not the bit that paces. I don't know if any of you have seen a pacemaker, but a pacemaker is made in such a way that just before the tip there is a short segment that is slightly thicker. That is the bit that paces, not the extreme tip. So cardiologists use their numbers or their values that they can see on their machine to judge where a pacemaker is pacing or not. If the pacemaker is pacing, the likelihood of it having perforated beyond the vessel, the cardiac chamber wall is extremely low. So sometimes you may think, oh, I'm very sure this has perforated beyond the myocardial edge, and you call them and you say, I think this is perforated, and they'll say, no, I don't think it is. The reason they are saying that they can see that the pacemaker is pacing if it's a pacing dependent patient. If the pacemaker is pacing, they know that that proximal thickened bit is where it needs to be. So how far could the distal tip have gone? A normal myocardium has a certain thickness, so you have to put the two together and realize that it's fine. If they are worried that there is pacemaker perforation, means they can see the values not making sense. They can see that it's not pacing as well as they want it to. That is when they will ask you for the scan. Or in the rare acute presentation, the patient is suddenly gotten unwell, they have a crushing chest pain, there's hemodynamic compromise, then that is when they will ask you for the scan. If you know it is for a pacemaker wire, it is worth telling the radiographer to up the kV, because you want to compensate for that metal. You want to look at the images in the bone window to compensate for the streak. And you have to again be reminded of the fact that it's clinically correlated, whether that's pacemaker perforation or not, especially when it's neither here nor there. When it's a straightforward perforation, there is a clear pericardial effusion that is high in density, that's hemopericardium, the tip is clearly beyond it, the patient is unwell. It's a very straightforward diagnosis. It becomes slightly more tricky when you put it in the sagittal. So first thing to do you would reformat the images and you would put it in the cardiac pains that I told you about in the beginning. If you can't do that, put it straight into a sagittal. You will be able to see the tips of pacemaker wires more clearly on a sagittal scan than you would on an axial. You put it on a bone window, you still window it even more to see where you think the tip is. That tip needs to be beyond the edge of the myocardium to convince you that this is suggestive of pacemaker perforation. When it's clear like that, so far gone, and there is clear pericardial effusion, it becomes more straightforward. When it is subtle like that, it's more tricky. So if you were to call that as suspicious of pericardial perforation, but the cardiologist is happy that it's pacing, and I don't think so, you shouldn't go around pulling a pacemaker out based on imaging. It is a clinical decision and should be led clinically. The other common scenario sometimes registrars get wrong is they seem to think that you can diagnose pericardial tamponade on CT. So pericardial tamponade is a clinical diagnosis. It is acute compromise based on a large pericardial effusion or constrictive pericarditis, or anything acutely constricting or preventing the filling up of the heart. That is pericardial tamponade. It is a clinical diagnosis. It is not a CT or imaging diagnosis. The imaging diagnosis is whether there is or isn't pericardial disease. So you will comment on the pericardial thickness, you will comment on the amount of fluid, the type of fluid, on on CT, even if you have convinced yourself that you think that there is straightening of the septum or there is bowing of the septum, I know this is right heart strain and this is, impending pericardial tamponade, cardiac tamponade, I would say don't, because if you then compare it even to a small pericardial effusion, you can convince yourself that this bowing of the RV free wall, you can see even when there is only a small amount of fluid. So don't use that to convince yourself that there is pressure because of that fluid. So don't use terminology like pericardial tamponade or cardiac tamponade on CT. The other pathology you may see incidentally on CT is acute MI. Like I said before, acute MI shouldn't warrant anybody a CT. What will happen in this scenario that I've shown is you can get a scan for PE, aortic dissection, poor history taking, or an incidental note, the patient is acutely unwell and they've asked the scan for another acute life-threatening abnormality. You can see marked difference in attenuation of a part of the myocardium of the left ventricle. The ability to see a RV infarct or a right-sided infarct on CT is extremely low, and the reason for that is that the RV wall is so thin that you can't really appreciate what density it is. So you shouldn't be acquiring CTs to look for myocardial infarction, but you can see them if you know what that is. When you look at it, you are able to diagnose it. Because of how fast the scanners are, this is a non-gated scan and you can see how clear the coronary arteries are. Part of that reason is because the coronary is calcified, so you can clearly see it. The coronary is a good chunky size, so you can clearly see it. And it's a good scanner in the lower heart rate. So there is almost no movement artifact even when this is not a ECG gated scan. That's how good the faster scanners are. So be mindful that you don't always need a ECG gated scan to comment on the coronaries. You can see completely occluded coronaries in certain people on a non-ECG gated scans. So unless you can convince yourself that this is a movement artifact or this is a low contrast opacification, don't discount the finding when you see it. Learn to recognize it when you see it, especially when it's unopacified. Don't comment on degree of stenosis on CT. You can't do that unless you put it in a software, you look through, do all what we talked about before, but you can certainly comment on a completely occluded coronary such as this because this is acutely life-threatening. The other pathology, this you must all be already quite good at picking up, is aortic dissection. The thing to remember about aortic dissection is it can look like a movement artifact, especially when it's near the aortic root. When we look at an aortogram, we automatically stop looking when we get into the heart. There is still a bit of aorta in the middle of the heart. There is still a likelihood of me having a dissection only limited to the aortic root. So when you see something like that, don't discount it as a movement artifact. It may be a movement artifact, especially when it's it's a non-ECG gated scan. So yes, it may be more likely that it is an artifact, and that should definitely be your first instinct. Can I explain it away as an artifact? But if you can't, the thing to do is to put it into a sagittal. An artifact, a dissection in an aortic root or aorta anywhere will show up more clearer on a coronal or a sagittal reformat than it will on the axial, because you can clearly see where it comes from on comparison to the wall. So when in doubt, put it into a coronal or a sagittal reformat. Don't discount it as artifact just because you're used to stop not noticing that part of the aortic root too much. Obviously, if it's a slower scanner, if there's a lot of movement artifact, this becomes less relevant. I don't want you to go ahead and start overcalling everything, but be mindful that not everything that looks like an artifact is an artifact. The other common pathology I wanted to talk to you guys about was what a normal post-aortic root replacement scan looks like. So people often diagnose that as aneurysmal or saccular or something like that, but this is a normal post-op appearance. What has happened is they have replaced the ascending aorta, not all of the aorta that was dilated. So this is the replaced one. The replaced ascending aorta doesn't always look very different from the native aorta. That's where the confusion comes from. And there isn't a clear clip always where the two join. The sutures are not, I lost my cursor, not always radio dense. So don't be alarmed when you see this appearance. This is a normal post-op appearance. Don't be alarmed when you see thickening along the root after an aortic root replacement. This is graft material. You can see dense material within it, something like this. Highly dense concentric opacities next to the aortic root. That is normal suture material along a replaced aortic root. Sometimes they replace an aortic root just above the level of the coronary. Sometimes they can reimplant the coronaries after during the surgery. So this is normal. This is not normal. When you see a bit of fluid, a bit of concentric thickening, it is normal. When you see significant amount of fluid that is going up to the the back of the sternum, that is not normal. It is not normal even 2 days after the scan. The surgical fields in cardiac surgery are usually pretty dry. Even for CAPG scans, if you notice them after surgery, they are very good. And the reason for that is off pump imaging surgery. So when you see significant fluid there, you have to see where you can connect it to. If you can connect it to there, and if you see few dense sac-like appearances, you have to be concerned whether that's a leak. A leak in a aortic root or aortic root pseudoaneurysm or abscess doesn't present as a sudden pop, sudden death, sudden collapse. It can be a slow, weeks, hours to months, not months, hours to days sort of presentation as well. Sometimes patient can present like that and they can stay stable like that for years. So sometimes you'll have serial imaging of these patients and you'll say, oh, if that was your first scan, you would immediately look at a scan from 6 months ago. And if it's still there, you realize that, they've had this post-op collection and they're just monitoring it. If the patient is asymptomatic, they're trying to leave it alone and see if it resolves. When you do see a collection like that, you want to see whether there is surrounding enhancement. This enhancement will show up more clearly if this was delayed phase imaging. So immediately in an arterial phase scan, you won't be able to see this enhancement really well. This will light up more clearly on a delayed phase. So the question would be, should you then acquire images in 2 phases? Should you then do an arterial phase and then do a delayed phase? Or should you do a split bolus? You give contrast in arterial phase, you give saline, then you give contrast again, and you acquire images. So you cover both. Uh, Depends on the center and depends on the confidence of the reporter. Having a bit of pericardial effusion is forgivable, but when you have a significant collection that you can trace back to around the replaced aortic root, that is not normal. And the other confusion people sometimes get is the difference between aortic root abscess. It's just a terminology thing that I thought I'd clear up, is pseudoaneurysm. What does pseudoaneurysm mean, and when do you call it a pseudoaneurysm, when you call it an abscess? An abscess means an infective collection. A pseudoaneurysm means a collection. So a pseudoaneurysm is an aneurysm that is different from a true aneurysm in the sense that you're missing part of the wall. The only way you can miss part of the wall is whether that part of the wall has died because of trauma, because of infarct, because of infection. So you can have every aortic root abscess either pseudoaneurysm, but every pseudoaneurysm is not an abscess, if that makes sense. So unless you know the patient history, the patient journey, you don't have to call it an aortic abscess. Pseudoaneurysm is a more correct term. You're describing a collection. The other question I am predicting some of you may ask is, why is that a pseudoaneurysm, not a true aneurysm? Because a true aneurysm in the aortic root dilates the aortic root. It doesn't just create small outpouchings. They can in some connective tissue diseases, but even then the likelihood the whole thing dilating is higher. In a true aneurysmal aortic root, small outpouchings, when they do form, you have evidence of why they've formed. So you may have an IV drug user, you may have post-RV scans, you can have post trauma, even iatrogenic trauma. Somebody went into the aorta to do some and they ruptured it. They left it alone because the patient was well, and weeks to months later they made a small. It created a small pseudoaneurysm. Pseudoaneurysm on a axial scrolling, when you're doing it quickly, can go unmissed. If you just saw that image, you say, oh yeah, that's the left main coming off. But it becomes more evident when you put it into a sagittal or a coronal or a LVOT view. These small outpouchings are described compared to which aortic cusp they are related to. So this, you would describe it, oh, it's the right coronary cusp, and just under it there is an outpouching measuring this much. So you're describing it for the surgeon, so he knows what he's looking for. When we do have pseudoaneurysms or aortic root abscesses, we try to do 3D reconstructions. It just puts it into context for the surgeon. Before the surgery, they can plan their surgery accordingly, they plan the incisions accordingly. So that's the difference between an aortic root and abscess and a pseudoaneurysm. Aortic root abscess is almost always caused by infective endocarditis. That can be patients with impaired immunity, or more commonly because of drug use. The other not so common pathology you may see is coronary anatomy abnormal, or it being a normal variant. So the coronary anatomy is coronary origin will be more and more visible to you because of how good the scanners are now. You may not give it a second thought if you're reporting on-call scans, but if the patient has presented with cardiac sounding symptoms or chest symptoms, it's certainly worth having a look, especially in a young patient. What they can have is abnormal origin of the coronary arteries. So the coronary arteries have the most commonly right RCA from the right cusp, left main from the left, and nothing from the non-coronary cusp. There are variations to that anatomy. Not all of them are dangerous. The word we use is malignant, so we call them a malignant anomalous origin or a non-malignant origin. What malignant means is something that is putting you at risk for sudden death or sudden, what is essentially an MI. What non-malignant means is it's not where it's coming from where it's supposed to come from, but it's okay, it's not going to cause anything. Whenever a coronary artery is pressed between two arterial structures, it is called a malignant course. For example, this RCA, it's coming from the left cusp and is going up, so it's squeezed between the pulmonary artery and the aorta. Those are both arterial structures. When they both pulsate, this will get pressed. If the patient was exercising or stressed or for whatever reason, if it gets pressed too much, it can give patient an MI. It can even present as sudden cardiac death. So the most common presentation of a malignant anomalous coronary artery is sudden death. So a lot of these diagnoses are made on an autopsy. They are made on coronary arteries now a lot more because just there is a larger percentage of people getting coronary artery cardiac CTs. The treatment for malignant origin of coronary artery is obviously to re-implant. They would cut that off and plant it to where it's supposed to be coming from. That is based for the right patient, the right scenario, etc., etc. I wouldn't get into how they select patients for that surgery, but that is the definitive treatment for malignant anomalous coronary artery. The other common pathology, probably the most common pathology in terms of chest outside the lungs for you guys on call, is a PE. So when there is a PE, there is a lot of enthusiasm to find right heart strain. There is a lot of overcall for calling right heart strain because of what we read in textbooks. What we look for is, the septum is straightened. There is tricuspid regurgitation because there is contrast in the IVC. These are the kind of things you put down in a report, and rightly so. But it is worth remembering because you have a lot of, a lot of these scans are done, or all of these scans are done by pump injectors. So in a weak patient or a small patient, a pump injector can inject contrast enthusiastically enough for it to end up in the IVC anyway. So just because you see a bit of tricuspid regurg or contrast going into the IVC, don't call it right heart strain. Right, the degree, if you have convinced yourself that you see right heart strain based on these two things, You have to look at the amount of PE the patient have. The patient has one segmental PE, or two bilateral subsegmental PE. The likelihood of that being significant enough to give them right heart strain is very low. So that doesn't add up. So don't overcall it in that situation. When somebody has saddle embolus, or big chunky clots bilaterally, then that same finding becomes more relevant. So what I'm trying to say is, put it into context. If it fits the narrative, then it carries more weight. When it's just subtle straightening, or what you have convinced yourself is subtle straightening, if you were to, I'm sure most of you will say that, oh, this, I think this is subtle straightening. If you put that into the cardiac views I told you about, if you put that into a 4 chamber and then turn that into a 2 chamber, so you could see the LV rounded and RV next to it, you would be able to see that this is not actually straightened. Context about whether you can see a cause for that strain. That could be a chronic, CTEPH sort of situation, or it could be an acute pathology. If it's an acute pathology causing that much movement of the interventricular septum, it is life-threatening. It certainly warrants a phone call. It warrants a critical finding alert. The other finding, in terms of trauma, just an interesting case to put forward is, people know that trauma blunt trauma causes cardiac contusions, and we know that cardiac contusions cannot be really be picked up very accurately on CT, because they are picked up by the clinicians, the cardiologists, based on the mechanism of injury, the patient demographic. So young middle-aged patient who doesn't look like they have significant disease, they have anterior chest wall trauma, and they have an abnormal non-specific ECG. That is where the suspicion for cardiac contusion comes up, and the way to confirm that contusion is by MRI, not CT. But cardiac contusion is not the only trauma you can get to a heart. Sometimes, very rarely, you can get lacerations of the myocardium. You can have bullet wounds, different kind of firearms. Some firearms turn into pellets, or turn into different fragments when they enter the body. So different pellets can go different places. These pellets can move as the heart beats next to them. So you can get small lacerations of myocardium. They can be asymptomatic. They can also look like what is a normal variant. So that's called a myocardial crept. So you can get what looks like a defect in a normal patient, and that's called a myocardial crept. And that is what someone may have dismissed this as, this defect in the myocardium. But in the context of trauma, you have bilateral consolidations dependent, you have pleural effusions that look a bit dense, and then weeks later the patient has developed, in that place they have developed a pseudoaneurysm of the left ventricle that is significant size. So that's just worth something to remember. It's a rare incidence, but something to just to put into the back of your mind. The last thing in terms of on call I will talk about before we go on a break again is a double and triple rule out. So double rule out is a scan that is done to exclude two pathologies, being aortic and PE. A triple rule out adds a coronary element into it. So triple rule out should be an ECG gated scan, or it should be a flash scan, so a quick tight spiral scan. So the jury is still out whether they are helpful or not. Whether you should be routinely doing a double or triple rule out in your on call, the answer is no, because it is hard to get a good triple rule out scan. And when you do get a suboptimal one, it is the PE part or the CTPA part that suffers, and that is actually more common anyway, having a PE or a small PE that may go missed. So it's not a, if it is done, or it should be done for a patient where nobody really knows what is going on, when the clinicians don't have a clear differential in their mind, or D-dimer isn't available, they want to exclude both pathologies. But it's those same vague patients that can have small PE and those small PEs can get missed when it's a suboptimal scan. So double rule out ideally should be left for very, very few patients that a clinician has no idea what they want to put their money on. So because it's not as good as picking one. The way to do it is different based on what scanner you have. The triple rule out needs a better quality scanner and more vigilant supervision of the scan. How you can do them? If you have slightly middle grade scanner, you can do it is you do it like a CTP CT Aorta, but you keep the contrast running for longer and slower. So you would reduce the rate of contrast and increase the volume, and you would do it like an aorta. So you would have opacified the descending aorta, and by that time, there is still contrast coming in into the right heart. So you have opacified both sides of the heart. If you have a faster scanner, a really fast scanner, what you can do is you can do a double bolus, um, or you have a phase sort of injection. You can give contrast, then saline, then contrast, depending. So it would have both on the same using for that you wouldn't have to increase the amount of volume of contrast you give. Using a triple rule out is when if you have ability to interpret the coronary arteries. Again, in those, coronary arteries shouldn't really be used. CT shouldn't really be used to look at acute coronary abnormalities unless you're looking for a dissection. So the take-home message is double and triple rule out is used for a very specific set of patients when nobody really knows what is going on. Sometimes those patients are post-transplant as well. So none of the specific signs you look for would hold because their whole anatomy is different. Understand what we use cardiac MR for. If you are interested in cardiac imaging, that is when you go and take a deep dive and try to understand it in more detail. If I were to explain that to you within an hour, I wouldn't be able to. If I was, it would confuse you even more. So I will try to simplify it and go for the ABCs for a junior registrar. Cardiac MR provision is even less common than cardiac CT provision. Some centers in every region, there are some centers that do it, and some surrounding trusts end up sending their referrals to that center. It is run differently, center to center. Some centers is cardiology run because there isn't the radiation problem anymore. This is a study cardiologists can verify on their own. They can run a service on their own. Some centers work like that. Some centers have the scanners, MRI scanners run by radiology, and that part of the service dealt with by cardiology, because having such an expensive machine and filling it all with cardiac MR can be tough unless you have a very huge service or an abundance of funding. So it is a complex scan. It is not a requirement for everybody finishing their training to be able to interpret a cardiac MR. It is extremely specialist investigation. But not just for the exam point of view, but for general knowledge sake, as a radiologist, you should be able to explain when somebody would need a cardiac MR and when it doesn't make sense to request one. The reason cardiologists slightly a more heavier presence in cardiac MR world compared to cardiac CT is because there is a lot of overlap between cardiac MR and echo. So echo is the oldest of all these techniques for cardiac imaging. And there is a lot of all the research data and the values, the validated, internationally accepted normal set of values for males and females is based on echo. And echo is, in the Western world, a cardiologist's domain, at least for the last 2 or 3 decades. So they are extremely good in echo. It is part of their everyday life. So there is being a lot of overlap between echo and cardiac MR in terms of the image presentation. So it would be extremely unusual for a cardiologist to be able to explain how a cardiac MR is done in terms of the physics of it. But if you give him the images of cardiac MR, they will be able to read it much uh, easier, because what the views look like on cardiac MR are very comparable to what they look like on echo. It gets very interesting when the scan is bad. So when there is an artifact in cardiac MR, that's when the cardiologist can't really interpret it as well as a radiologist, because the radiologist will have the the background physics knowledge to be able to understand why that artifact is there and what we can do and what the different sequences mean. And that sort of setup of the service is more heavily reliant on a radiologist or a radiographer even. um, so there are strengths and weaknesses to both specialties in terms of cardiac MR. The values we use in cardiac MR for normal are the values we use for echo. There are no validated values purely of cardiac. There is a lot of research data, a lot of different sorts of avenues being explored at the moment internationally. None of it is as heavily accepted. Still, echo is, those values are still used for every scan we report across the world. So cardiac MR is different from cardiac CT in the sense that cardiac MR is a cardiac MR. When a cardiac CT is essentially a body CT looking at cardiac structures, you have to reconstruct later on. Cardiac MR is acquiring images of the heart. It is making sure it is going by the axis of the heart. It doesn't care what the body around it looks like. It doesn't need patient to be in a certain position. It can acquire images going off their localizing sequences. So it will acquire the four-chamber, it will draw a line through it, get that view, and so on. It will keep cutting and getting further and further views, and all those views will be catered towards the heart rather than the thorax. The scan protocol in cardiac MR, there is a certain protocol. The protocols are set up in every department. There are routine protocols. They are not changed very often unless the indication or the scan shows an abnormality that requires it. Cardiac MR, same as cardiac CT, needs a stable heart rate, but it is slightly more forgiving of irregularity compared to CT. It can acquire an image in arrhythmia. You can force it to acquire image in any heart rate, any rhythm. The quality suffers, and what that arrhythmia will do is it will make the cine or the moving dynamic images worse. So you can't do the calculations. The calculations need a very clear artifact-free sort of cine loops across different parts of the heart. The irregular the heart, the faster the heart, that is what compromises. The static images, the ones we use, the contrast, etc., that I'll go on to in a bit, those don't suffer that much. So in that scenario, you can still use echo as a backup for those measurements and still use MR for the the scar or the contrast images. Claustrophobia is a huge issue in cardiac MR. It's an issue for any MR, but cardiac MR is a long procedure. It can minimum 40 minutes patient spends inside the scanner, no matter how quick you want to go through all the images. It is a long time to be in a small space, especially if you suffer with claustrophobia, especially if you're big, because you can't make the bore any bigger. Because you have heart patients, they have trouble lying down flat anyway. They may get breathless lying down, they may have pleural effusions. And on top of that, a bit of claustrophobia, and ask them to lie down still supine for 45 minutes. They do struggle sometimes. They have to be able to follow breathing instructions. Some of them are breath hold. If they can't, we can compromise and modify the technique. We can do a free breathing sequence. It is not as good, but visually it still gives a lot of information. It's still better than not doing it. The one requirement cardiac MR has that CT doesn't really have is you need height and weight of the patients before you do the MR. The reason we use that is what is normal for myocardial mass, ejection fraction, all those values that we use, on echo or a cardiac MR, are not what is normal for me may not be normal for, a 5-foot person or a 6.5-foot person or a bigger person or a smaller person. Everybody is different. You take into account the height and the weight of the patient and the gender, and you calculate the the body mass index, and you then use the normal values for that bracket to say whether that patient's heart or that chamber is dilated or not, impaired function. um, and you will see that when you do indexed values, compare them based on their body mass index, or body, sorry, keep saying body mass, body surface area, you you get a more accurate depiction. So what may look like is a dilated or impaired heart, when you do it compared to body surface area, they may turn out to be in the normal range. EGFR is important because you're going to give contrast if you're doing a viability scan. History of prior surgery and metalwork extremely important. MRI safety checklist and all that. ECG leads are placed same as CT. In terms of the sequences, the cardiac MR sequences can sound very complex. It can sound like completely different language, even for experienced cardiac, experienced MR reporters. The thing to remember is cardiac MR doesn't speak in T1, T2 language. We don't say T1 weighted and blah blah and all that. We say we speak in more specific terms. If we use loose terms, they are loose terms based on what color the heart is. So you will hear the terminology white blood imaging, black blood imaging in cardiac MR. The two types of image acquisition you do is gradient echo and spin echo. You can do phase contrast imaging, that is to have a measurement, that is to provide a measurement of how much volume you think is coming through a certain vessel at a certain point. You can do that to look at flows. That comes very handy when you're doing congenital imaging, when you have shunts. For example, if there is an AST, you would do, I would look at how much, for example, if I would look at how much the ejection fraction is. I would look at the flows through the pulmonary artery. I would look at the flows through the aortic ascending aorta. I would then calculate what is called a QP/QS ratio. Again, I don't want to confuse you too much, but you can do all these systemic to pulmonary flow ratios. If they are not one-to-one, you realize there is some blood going somewhere that I can't see, not through the right channels. So that gives you an indication that may be a shunt somewhere. If you can't see it on the images, you can do CT to look for them. The shunt can be in the lungs as well. They can have an ABM. So it's phase contrast imaging is very important to calculate flows, to calculate shunt quantification. Contrast imaging is to look for scar. Contrast imaging is done early contrast enhanced images, delayed contrast enhanced images. Delayed contrast enhanced images are the most important part of the whole study to look for scar. I'll come to that in a bit. Mapping is the newest technique that is out. Mapping is essentially giving you the same information as delayed contrast enhanced images, even better actually, without giving contrast. So it's like it's like doing a virtual biopsy. It is giving you information about the morphology of tissue without giving them contrast, without doing a biopsy. It is an extremely exciting development in cardiac MR. The last year or so has really seen it take off. Not all centers do it, but it is the latest development. I won't presume to expect you guys to understand that, so I haven't put that in here. But you're welcome to look up a video on YouTube or Google it, read up about it. It is exciting and it may spark an interest in cardiac imaging for some of you. Like I said, gradient echo and spin echo is the main stay within cardiac imaging. And the benefit of gradient echo being that it's faster, but how you can quickly tell them apart is the gradient echo is the white blood. The bad thing about it is you can see motion of the heart. The functional assessment, because you want to see that motion, you do your cine or your dynamic imaging. It's called cine loops, cine imaging, short axis cine imaging. It is used to calculate exact ejection fraction, systolic stroke volumes and diastolic volumes and stroke volumes, same as an echo. That is done on gradient echo. Spin echo is black blood imaging. It is used for static imaging. It gives you information about the anatomy, and that's to produce any pretty thoracic imaging around it. What comes with it may come with it. They're not bothered with it. The mainstay of the imaging is focusing on getting the right plane of the heart in every view. If it is a fourth chamber, it is concerned with only the four chambers of the heart. A fourth chamber is what you would say the long axis or cut through like a horizontal slice of the heart, looking at the RV, LA, LV. Two chamber, the two chamber can be a long axis. So in a long axis, you're looking at the LA and LV. The two chamber can be a short axis. What that means is you're cutting, if this the two ventricles are side by side, you're cutting it in half and you're looking at them. So you can see the cross section of the both ventricles. That is a short axis two chamber. We do a short axis cine stack is what I meant during different places, like the base of the heart, the mid of the heart, the apical part of the heart, different places, multiple times we're doing cine stacks. What we then use them for is we put them into a cardiac software. This is usually vendor specific, so it's not it doesn't really depend on the machine. We usually buy them externally. Tenericon and CVI Circle and these sort of the big providers. They are good softwares. You previously had to draw the outlines of the LV or the RV for every stack. That's certainly how it was when I was trained. Now the softwares are smart enough that they automatically pick the outline. The outline is imperfect. You know, it's a machine trying to draw it for you, so you still have to go through it. You have to correct it. A crude way of correcting is you see the amount of the volume of blood coming out of the aorta, and then you see what you've calculated is coming out of the LV, and you want there to be an acceptable difference, about 10 ml difference. With seeing a 30 ml difference between them, either there is a shunt that you're missing, like there is an VST that the blood is going in there, or there's a miscalculation on your part. So that's one way of doing it. We can also do LVOT views. Those views are very important in hypertrophic cardiomyopathy. What you're trying to see in that view is you're looking at something we call SAM. So it's the systolic anterior motion of the mitral leaflet. You can see how the thickening of the interventricular septum is impacting the LVOT. So patients with hypertrophic cardiomyopathy may or may not have obstructive cardiomyopathy. And what it means by obstructive is, it is called obstructive when it obstructs the LV outflow tract. That is why the LVOT view is so important. You can have hypertrophic cardiomyopathy and never have obstruction. You can have very mild hypertrophic cardiomyopathy, but it's centered on that part of the septum that when you see in the LVOT view, you can see that every time the blood flows through it, it's really narrowed over there. So that makes it more, puts the patient more at risk for symptoms or even sudden death. RVOT views are done less commonly. They can be done when the question is predominantly about the right heart, and that is based on the clinical assessment. Then you get specific questions about specific pathologies. So you can have a follow-up for a congenital problem or a congenital correction. In those, you modify your protocol accordingly. Radiologists sometimes sit in the scanner. When such a patient comes, if the radiographer isn't sure about what they're looking at, they can't figure out where what is going into where, what the anatomy is. That's how you help them plan. Patients who have shunts or post correction of congenital heart disease, they can have strange shunts or strange connections. Those connections also need flow imaging or contrast. You need phase contrast imaging to see how much flow is going through those, because over time the abnormality these patients get is that they get stenosis. So this is again a few images showing, this is a 4-chamber view, this is a long axis 2-chamber view, this is a short axis 2-chamber view. These are the tribulations of the LV. These can be normal if they're few. If they're too much, that they're encroaching upon a lot of the lumen of the LV, you can have something that is considerably rare. It is called non-compaction, where the trabeculation is actually preventing the contractile function. That is the cardiomyopathy. This is just a label image of the same thing. The endocardium is not distinctly separable from the myocardium. So when you hear words such as subendocardial or mid-myocardial, it is not a distinct line that differentiates them. It is just where you see the abnormality predominantly sitting. The epicardium again is not clearly differentiable from where it starts. It is just assessing based on the location of it. Stir imaging is done like any other body part, is to assess for edema. The reason we do it in myocardial imaging is to look for myocarditis. And only in early myocarditis would you have edema. If somebody has myocarditis and they healed up or they're on a follow-up scan, they can still have a scar, but they may not have edema anymore. So edema means acute issue. You can see it in myocarditis. You can also see it in acute myocardial infarction. The issue that when the tissue is, vascular compromise or reperfusion edema even. So edema is, they're fat suppressed images, and edema is bright, same as any other image. So that's not very different in cardiac MR. The uses of cardiac MR are few in the sense of categories. The function is a non-contrast cardiac MR. You don't really need to give contrast if you're just doing the function. It is just a way of, for example, saying it's a cross-sectional echo even. You're getting the same information that you would get from an echo without it being user dependent. So echo is a handheld, it's a sonographer or a cardiologist doing it. And depending on the patient habitus, the patient may be big or they may be, not be able to allow the cardiologist to do it. So cardiac MR comes in handy in those patients when you are not sure of the values that you're getting with echo. So that is a function, cardiac MR for function, that does not require contrast. It is just the cine stack views that are helping you get the function. When you say cardiac MR for viability, viability is when a cardiac surgeon wants to know how much of the myocardium is dead and how much is left. The reason they want to know that is they want to assess whether the patient is a candidate for revascularization. Is there point to putting in, doing a cabbage? Why should I revascularize a region of the heart when it is already dead? That is why we do a viability. The viability issue with cardiac tissue is you assume that anything that is showing scar for more than 50% of its thickness is non-viable. That is the rule of thumb we use. It is somewhat crude, but that is how it is reported on cardiac MR. So if you would see a segment of the myocardium in the LAD territory and it is more than 50% enhancing on delayed myocardial images, I would say that that is non-viable segment. The cardiac tissue of the LV is divided into segments in short axis. There are 17 segments. There are 3 coronary arteries that supply the LV. These different segments belong to different arteries. We calculate the numbers of segments, we count the number of segments that are non-viable, and the report then states that this many out of 17 segments is non-viable, this many is showing infarct, but it's still viable. And that is then a discussion for an MDT whether they want to proceed or not. And that also tells you which arterial territory is the non-viable one and which is still worth saving. The third indication is to assess for cardiomyopathy. When the cardiologist thinks that the patient's function or there's something wrong with the heart, but they're not quite sure of the diagnosis, they think the patient has some sort of cardiomyopathy. What it is, they want to confirm it, they want to see the extent of it, and they want to see whether we can narrow down the differential diagnosis based on the distribution of the scar. Cardiomyopathy is a very generic, very broad term. It just means anything wrong with the myocardial muscle. It can be ischemic cardiomyopathy. So anybody who has a large myocardial infarct can have deranged LV function, and that is called ischemic cardiomyopathy. So MR is very good in differentiating ischemic versus non-ischemic cardiomyopathy. In non-ischemic cardiomyopathy, you then depend on a few patterns that you look for to help narrow down the differential even further. And the last part we use cardiac MR for is stress. Stress is when you give the patient adenosine or dobutamine or regoranosine, adenosine being the most common and assumed to be the safest, is when you stress a patient, similar to what was exercise tolerance tests or stress echo, etc., when you know the patient has ischemia, they have symptoms, they have disease on cardiac CT or invasive angiogram, but you want to see the extent of that ischemia, you want to confirm that ischemia, or you want to make sure when the patient keeps saying, oh, I go up the hill and I'm walking, I get a chest pain, and you want to see whether that is actually real ischemia or that's just the patient feeling that way. So that is something called stress imaging. The patient stays on the MRI table. They are given adenosine calculated very accurately based on their weight. It is done by somebody trained in resuscitation because there is a risk with adenosine inducing complete heart block. It can not so uncommonly give patients transient complete heart block. So you would see it happen while you're stressing them, and they usually come back for it. If God forbid they don't come back for it, there is no immediate antidote to it. But the half-life of adenosine is seconds. So within a few seconds, when you stop adenosine, the effects of it have worn off. So technically, if you think about it, it is too short an interval to actually give somebody myocardial infarction. So that stress imaging is to look for inducible ischemia, whether you don't have scar, but they have stenosis. Do they actually get ischemia? If you can prove stress-induced ischemia, that makes them eligible for definitive treatment or stenting, etc. This is what I meant with viability. The image on the left, you can see subendocardial. So the word you're looking for when you want to say it is, or when you're looking for ischemic cardiomyopathy or ischemic scar, the scar starts from the subendocardial or the innermost part of the myocardium. It starts from here always. That is the hallmark of it being able, or us being able to label it as ischemic. The extent then goes outwards. So the bigger the infarct, the deeper it will go, the bigger it will go. So sometimes when it's so big, it can get to the entire thickness of the myocardium. At that point, it is unrealistic to assess whether it started from outside in or inside out. There is no pathology that starts from outside in and focuses on one coronary artery territory other than coronary artery disease. So that is a complete distribution of a coronary artery, and you can see that it is almost transmural. So that is a large myocardial infarct. All of that myocardial muscle is non-viable. So if you were to put it on cine stack, this part would not be moving that well, or maybe even moving in the opposite direction of what it's supposed to be moving in. And this is the segment model I was talking about. So basal, mid, and apical segments is what we cut the heart into. Basal segments are 6, the mid segments are 6, the apical segments are 4. And then there's an extreme tip is the true apical segment. This model is what you would keep in your mind to calculate the number of segments and label the segments accordingly. So that would be the anterior wall. That would be the inferior wall. So it's not anterior and posterior, it's the anterior wall, inferior wall, lateral wall, and septal wall. The anterior is not in relation to the body or the front of the body, it is anterior in that image, if that makes sense. The terminology is different. Cardiomyopathy, again, if it's not ischemic cardiomyopathy, cardiac MR can very accurately tell you it's not when it is not predominantly in the subendocardial distribution. A non-ischemic cardiomyopathy sits mid-wall or even within the epicardial region of the heart. So that is the hallmark of having non-ischemic cardiomyopathy. I will go back to cardiomyopathy distribution in a bit. I want to go through the stress images again. Stress images are acquired dynamically. The patient is on the table being given adenosine while those images are acquired, because obviously if you stop adenosine and then start images, seconds would have gone by and the effect of adenosine would have worn off. What you want to see is considerable increase in heart rate when you give them adenosine to be sure that adenosine is acting or they're responding to it. Then only should you acquire images. You do it for a while and you're not seeing response, you just acquire the images anyway, noting that maybe the patient doesn't have symptoms. Sometimes patients with very diseased hearts don't notice adenosine. They don't have those symptoms that a normal person would be. And the way to explain it to the patients is you may feel that you're suddenly running up 3 flights of stairs, and how would you feel? For a young person, it's easy to understand. For an older patient who hasn't run 3 flights of stairs in years, and to have it lying down flat, it can be quite daunting. And the symptoms they get is ischemic symptoms. They get chest pain, they get tightness, they get breathlessness, and you can usually tell by looking at the patient that they're feeling it. So a radiologist or a cardiologist would be injecting, standing next to the patient, watching their heart rate, and then telling the radiographer, go. I can tell that the adenosine is acting. Once the images are required, you stop the injection straight away, and you have to be very grateful that you have stopped it, because like I said, it is a dangerous drug, or it can be. And this is the image I was talking about for non-ischemic cardiomyopathy. Is the distribution helps narrow it down somewhat to the differentials. One differential that has a very typical distribution is hypertrophic cardiomyopathy. So hypertrophic obstructive or non-obstructive cardiomyopathy has a very distinct pattern of enhancement that it does it at the insertion point. So what we call it insertion points are the it's called the RV insertion point, is where the RV touches the LV. They have very prominent enhancement in these areas, especially when the whole of the myocardial is thickened. There is hypertrophy. You see this typical enhancement. So that's very correctly put it together and say that's hypertrophic cardiomyopathy with scar. You can get mid-wall enhancement in any myopathy. You can get it in non-specific areas. The presence or absence of scar determines the prognosis of the patient. So even if you can't tell how it fits into a very specific diagnosis, your information that they have or don't have scar is still the most valuable information the cardiologist needs, because that means whether they will get follow-up, they will get treatment, they will, how they will progress. It is a prognostic factor as well. Sarcoidosis, amyloidosis are some very specific diagnoses. Sarcoidosis can present with mid-wall enhancement. It is easier to pick when the surrounding lung is also abnormal. Sarcoidosis is a multi-system disease, so you can get sarcoidosis below the diaphragm. You can have prominent lymphadenopathy. You can have splenomegaly. You can have splenic lesions. You can have mediastinal lymphadenopathy that would show up on the localizer slices of the cardiac MR. You can see if the lung changes are very prominent, you can even see them on cardiac MR, but obviously you would want to follow that up with the CT. Anderson-Fabry disease is quite rare. Chaga disease is extremely rare. It's a very South American, rarely seen in the UK sort of disease. Purely academic at this point of time in terms of your day-to-day practice. Epicardial hyperenhancement can be seen in myocarditis. The reason it is seen commonly in myocarditis is commonly seen as myopericarditis or perimyocarditis, however you call it. The pericardium is inflamed and the myocardium is inflamed. So the pericardial enhancement may show up as epicardial enhancement, and then you have the mid-wall enhancement. So myocarditis can have epicardial and mid-wall. At that point, you should really be calling it myopericarditis. You can have sarcoidosis showing that as well. When you have global endocardial, it's like a rim of all around hyperenhancement. The likelihood of that being ischemic gets very low, because all 3 coronary arteries can't get infected at the same time, the same extent. So that clear rim is a very striking appearance. It is a very rare appearance. It is seen in amyloidosis and systemic sclerosis. One thing worth noting is in post-cardiac transplantation, it is seen for mechanisms not well understood, and it is almost expected to be normal in those patients. So those are the few cardiomyopathies you can think of if you see a certain distribution. Plenty of papers available online if you do get confused and you want to read up on this more. Cardiac MR has limitations. It has slightly more limitations than cardiac CT does. And the reason it does is, number one, availability. It's not available. It's available even more rarely than cardiac CT is. it really does require patient fitness a lot more. It's a longer scan. You need a compliant patient. You need a certain fitness to be able to follow instructions, to be able to lie down flat, to not to be claustrophobic, and you then have to go through the whole checklist of normal contraindications to cardiac MR. Having metal doesn't prevent you from getting cardiac MR. Having a pacemaker does not prevent you from having a cardiac MR. Having a pacemaker and needing cardiac MR does require a pacemaker technicians. They have to be present the whole time for the scan, because they have to do the pre-checks and the post-checks to make sure the pacemaker is working properly after the scan. Any resuscitation equipment in cardiac MR needs to be MRI compatible. If that patient does develop a complete heart block while stress is being given on the table, if you don't have resuscitation equipment compatible, the only thing you can do is bring the patient out, and by that time, hopefully the crash team would be there and they would take over from that point on. It has advantages over cardiac CT. Number one being radiation. You can do it in pregnant patients. You can do it in in utero. Cardiac imaging is also being performed for fetal birth defects, cardiac defects. If the patient needs serial scans, if they have connective tissue diseases, we do a Louis-Ditz protocol for people with connective tissue disease. They come in every 2 years to have a scan. It's just do serial measurements of every vessel in the body, so they have a whole body angiogram. Doing a whole body CT every 2 years for the rest of their life, from when they might be 17 years old, is quite high, the radiation dose. So those patients should be having MR. That is the edge MR has. Pre-op, you can quantify the shunt, the severity of the shunt. That cardiac CT cannot or should not be doing a high dose retrospective scan like that. Post-op surveillance for corrected congenital abnormalities are done by cardiac MR. It is the mainstay of them because obviously it gives you function and morphology at the same time, which cardiac CT doesn't. In the end, I would say the cardiac imaging can seem like a very complex field. It shouldn't be for a radiologist. And given the shortage, I would implore more of you to consider this as a subspecialty for you to develop. Again, what's commenting that some of the most common life-threatening cardiovascular abnormalities don't even need cardiac imaging. They just need you to be aware of them. And with faster scanners can easily be picked up on even non-dedicated cardiac scans by all radiologists.